All right, everybody. Welcome back from fall break. And as I can see, some haven't gotten back yet or got used to sleeping in over last week and they're not here. Doesn't matter. Those of you, thank you for coming. And I didn't get a chance to check the class calendar. I believe I'm supposed to conclude the bone lectures today, if I'm not mistaken. So at least I'll work toward that goal and I should have plenty of time. There's no quiz or anything like that today since you were on break last week. So this is where I left off. Remember, in the first lecture about the bones, all I was doing was talking about jargon, giving you anatomy, to talking about the difference between cortical or dense bone and trabecular or spongy bone, etc. All right. I also talked about how bone follows blood. It's highly vascularized. In fact, if you deprive bone of blood, it dies. All right. And this is because bone is highly metabolically and endocrinally active. All right. So it is an extremely active tissue. I just take from your mind that it is just a simple support structure. It's an extremely active tissue, set group of tissues. All right. So what I want to do, I talked about, for instance, long bones and flat bones. I also want to talk about where the bones come from. All right. There's two ways that we talk about bone formation as osteogenesis. There's two forms of osteogenesis. One of that consists of where we have a stem cell population. It differentiates into these pre-osteoblastic cell types. They then produce what they differentiate directly into bone. So we go from stem cell populations to bone directly. This is referred to as primary bone formation or direct bone formation, right? This is typically associated with flat bones, such as your skull. All right. Now, long bone formation has a more circuitous route. It is referred to as indirect or endochondral bone formation because we do not go from a stem cell population to pre-osteoblast to osteoblast to bone. We go from stem cells to chondroblasts, cartilage type tissue, and that gets remodeled and replaced with bone. So that's why it's called either secondary bone formation or endochondral bone formation, because there's an intermediary cartilage step. All long bones are formed in this manner, and we'll get into more detail in a moment. But those are the basic two mechanisms in your body whereby bone is formed. Now, and this is just to demonstrate in the visual aspect, this intramembranous or primary ossification. We have this stem cells, they differentiate pre-osteoblasts. They then are starting to form bone, and it's direct. Again, there's no cartilage intermediary. It's very straightforward. At the end, for instance, here is a flat bone, such as your skull. You have your cortical bone on the outside, and you have your trabecular bone in the middle. And of course, your osteoblasts are on the surface. Right? Endochondral bone formation associated with long bone formation. So here we have a developing embryo, and these initial long bones, this could be a humerus, it could be a femur, it doesn't matter. They're all long bones. They begin life as this dumbbell cartilage shape. There tends to be a collar of bone around the metaphysis, the outer metaphysis aspect here. Then there could also be a little bit in the middle. All right. Now, eventually what happens is the bone starts to expand, and it starts to, as this cartilage grows from either end, the center starts to alter. We get a bony collar all the way around the metaphysistic aspect of this long bone and the shaft, basically. And inside there starts to form a marrow space, and the cartilage is being replaced with bony tissue. Remember, bone follows blood. So a critical aspect of this is the invasion of this cartilage type tissue with blood vessels that then promote the osteoblast and the formation of bone. All right. As time progresses, we start to see islands of bone forming at either end, right? And both the proximal and distal end. Eventually, what will remain will be a surface coating of cartilage on on both the distal and the proximal ends of the long bones. And then inside the actual distal and proximal aspects, we have something referred to as the growth plate. These are pre-chondroblastic stem cell populations, and they persist throughout the growth phase. So from in utero all the way to the point where this growth plate closes. Ladies, around puberty, guys, a few years later. All right. But once it's closed, it's closed. But while it's open, what happens is that these osteoblastic cells will replicate, and they can't go this way. They can only they grow on either ends out because there's already something here. The only room to grow is going in this right direction. So those cartilage cells are replicating themselves, and they keep going up this way. That's either in, so the growth plate is here, so everything is pushing in this direction or pushed in that direction. So simultaneously, your bone extends, these long bones extend from each end, all right? Equidistant at time. Now, what happens is these are new osteoblasts. They keep going up this way. These these chondroblasts mature. They tend to die to become mineralized. This is not bone because it's cartilage. And these then get resorbed by osteoclasts. That then leaves room for osteoblasts to come in, replace them when we get bone. So the thing about long bones always grow from end to end this way, outward, right? This is why it's critical during childhood. If you have any sort of damage to the growth plate, this is extremely important. It's what happens if you disrupt that growth plate. Let's say we have a femur and the growth plate up here is damaged. The one this is proximal next to the pelvis, whereas this one above the knee is not damaged at all. So this one grows normally. This one stops growing because it's been damaged in this trauma event. What does this mean? This means that we're only growing not end to end, but only one end. So that means it's going to end up being shorter than this one. So you'll end up with a shorter limb, a shorter femur, therefore a shorter leg length at the end of the day. All right. So it's really critical, especially when you're dealing with growing children, especially when it's close to the closure of those growth plates. You do not want to do anything that's going to damage those growth plates because that will disrupt the normal growth of those bones, right? And lead to significant problem. It will create significant problems for such children, right? Now, I told you that one function of bone is to act as these internal support structures. They allow me to stand up in front of you. Otherwise, all the soft tissue would just be kind of sitting here on the floor. All right. So they have to obviously resist stresses, gravitational stresses to be exact, or me moving around, the weight of my body, etc. Right. So what I want to talk about is bone and stress. Right. So what we can say is this. Let's use as an example. I'm going to use the femur. That's this bone here. And you have two of them, most people. And all the weight from pelvis up is transmitted to the floor, to the center of the earth via each femur. All right. So that's all the soft tissues, all the tissues from here up. Everything's transmitted to each of those femurs, and it goes from my femurs all the way to my knee, all the way to the floor. If I lift up one leg, now it's all going through one femur. All right. So the femurs in your body they are long bones, but they're not straight bones. They have a slight curvature, an outward curvature. That gives them the ability. Bones are not rigid structures, as I talked about in the prior lecture. They are semi-rigid structures. They bend. Okay. Now, so what I want to talk about is how they adapt to stress. All right. Forces applied to them, in this case, gravity. So all the weight that's forcing down, there's a slight curvature to the outside like this. So when the weight comes down, there's two types of forces that are being expressed on those bones. Those bones that are on the outside, this has a slight bow, that means they're under tension forces out here. Those in the inside are under compressive forces. So the way to think about this is think of a bow and arrow. It's exactly the same thing. That bow, when you pull it back, the inside of the bow is under compression. The outside of the bow is under tension. Now that bow has to resist both of those forces simultaneously, as does your long bones. They do the same thing, all right? So they have the capacity to resist both the stresses of compression and tension. Then there's also the rotational type forces, and they can resist those as well. Now, let's think about cartilage for a minute. At the end of this series, I will spend some time talking about cartilage, but I want you to remember that cartilage is unique in the body, that it is avascular. It does not have a blood supply. However, that tissues are larger than a millimeter cubed. They're significantly large. Well, how does gas exchange occur? How do nutrients get moved in and out of those cartilage tissues? It all has to do with mechanical forces, right? So what is cartilage? Cartilage is basically a hydrogel, or if you will, a sponge, all right? A sponge filled with water, all right? So if you take everyone has a sponge, or at least knows what it is. You have a rimmed plate. I take a sponge, I fill it with water and let all the water drop out. It's going to, because it's hydrophilic, it's going to contain a certain amount of water, right? That's associated with the open cell structure of the sponge. Lay it on that plate. The water stays in the sponge due to this hydrostatic pressure differences, okay? Now, put your hand on it and gently squeeze down. What you're doing is you're compressing those open cells, which are filled with water. That's going to expel the water, and you'll see water leaving the sponge, filling the plate. Now, slowly release the pressure. What happens? Water is drawn back into the sponge. So by repeatedly compressing and relaxing those compressive forces, the water will leave and re-enter, leave and re-enter. And this is exactly what happens to the cartilage. For instance, here in my knee joint, all these long bones on either end is cartilage, okay? So that as I'm walking around, what's happening is that spongy material, that cartilage is doing this. It's compressing and relaxing, compressing and relaxing. So that means liquid, including oxygen and CO2, nutrients and things like that, are being pressed in and are leaving and entering, leaving and entering, all right? So that's how these repeated rhythmic forces can maintain the viability of this cartilage tissue, despite that cartilage tissue being avasculature, having no vasculature. Now, I want to introduce the concept of Wolff's Law. Wolff was an individual who lived in the mid-19th century, and he made some observations. He initiated his work with cow bones, and he used to cut cow bones, split them longitudinally, and look at them. And he would look at them, because this was before x-rays. He would look at them and say, well, there's a pattern to this bone, all right? And he contemplated the patterns, and he was able to say that, well, wait a minute, we know a little bit about stresses, and then there seems to be more bone where there's expected to be more stress applied, and hence Wolff's Law, all right? So let's look here as a practical application of Wolff's Law. So at the top, here's all the various stress lines. Remember, both compressive stress and tensional stress. On the outside bow, we have tension. On the inside, we have compression. Notice how the stress lines will come from, there's two aspects to the head of the femur. Over here, this is the ball of the femur. This fits into the pelvis joint. This is my acetabulum. Here is the head of my femur, and it's a ball and socket joint, which allows my leg to move around and up and down, right? This over here is the trochanter. It's a huge lump of bone, which my gluteus maximus, that's your big butt muscle back here, that's physically attached, right? Now, what happens is if we look up here at the expected stress lines, and if we look down here, we can see that corresponding to these expected stress lines, we can see more bone, this going radiating down this way, and then down in here. And they reflect the predicted stresses that will be that these bones will encounter. So basically, that means that the bone has remodeled in order to resist these stress forces being applied, because that's what it's designed to do. All right. Now, remember, your bone is being remodeled throughout your lifetime. It's responding to changes in physical forces, i.e. stresses being applied. Right? When you are under greater stresses, say you're exercising, your bones will adapt to resist those stresses. Let's say we have interstellar space travel and we start colonizing different worlds and around different stars, and some of these worlds are high gravity wells. So we live in a gravitational well of 1G. What if you went to a world with a gravity of 2Gs? All right? Your bones would have to adapt in order to survive. And now this is over time. And think about, okay, or let's go the other way. So, we're supposed to be returning to the moon here in the next 10 years or so. And now we have people living on the moon, which has significantly less gravity, obviously, than Earth. And just imagine people living, colonizing the moon, living on that. Now they're in less G gravity forces. And think about thinking about Wolff's Law here. What would those two types of colonists on the moon, colonists on a 2G world, what would they look like over generations of time? Right? Less stress is being applied on the moon, so they would tend to be taller. Okay? They would tend to be taller because there's less forces pushing them down. Whereas those in the 2G world would be shorter, heavily muscularized to resist those gravitational forces, right? So this is all applied Wolff's Law. So let's get to what I want to talk about, the practical observations that are associated with Wolff's Law, all right? So number one, long bones are thickest where they're most likely to buckle around the middle, and spongy bone forms trusses and struts. Remember that. I showed you those pictures in the first lecture. And they are designed to provide stress relief with the minimal amount of bone. Okay? And large bony projections. Remember, I mentioned the trochanter on the end of the head of the femur. This is where a big butt muscle is connected. That muscle wants to rip that bone off. And in order to resist that stress forces, the bone remodels to have greater bone there. And there are instances where we can change load. Let's say that either you go to the space station, bless you, or you're bedridden for 6 weeks or something like that. In other words, if you're not applying stresses to the bone will remodel. Remember, I keep telling you this from the introduction to present, that life is not cheap. All of the nutrients, everything that is part of your life is expensive. Your body will not just say, it doesn't have enough to say, well, we'll just maximize everything. What it does, it promotes resources where and when they're needed. All right? It shifts resources. In other words, it robs Peter to pay Paul. So that means if I don't need resources in my left arm, the body is going to take those resources and allocate them elsewhere. Okay? Because there's never enough to go around. So if I am bedridden, my bones are not exhibiting stresses beyond just simple gravity pushing down. I'm not exercising. What's going to happen is your body is going to take stuff from those bones and reassign it elsewhere. All right. So what's going to happen is you're going to lose bone. As you lose bone, that means you lose bone strength. Okay. Now, That boils down to the simplest definition of Wolff's Law is this. I cannot get any easier. Either you use it or you lose it. That's applied Wolff's Law. Use it or lose it. All right? Now, Wolff's Law was obviously designed for bone. However, it's directly applicable for all musculoskeletal tissue, i.e., skeletal muscle. So when you go to the gym, you go to Planet Gym or whatever they're called now, and you're doing resistance training. You're doing those barbells. All right. What happens? Your biceps muscle gets bigger. All right. So it's getting bigger, and we already know it's getting bigger. It's adapting. We're getting larger muscle cells. Right. So the circumference of that muscle is increasing. What happens if I quit exercise because I'm not paying my monthly charges? It's too expensive. I don't exercise. What's going to happen? That increased circumference goes away with time. That's all applied Wolff's Law. All right. Okay. Let's change subjects and go to bone repair and regeneration. All right. I've been doing tissue engineering, regenerative medicine for about 40 years. And most of my early work, and to some extent even today, I work with musculoskeletal tissues. I was originally 10 years in orthopedics. All right. So basically, one of the things when we talk about the early aspects of tissue engineering, there is one tissue that readily regenerates. Well, stop. Let's define what's the difference between repair and regeneration. They're related, but they're not the same thing. Repair is such that you will recover function, but not form. So think about your skin. Your skin serves as a protective boundary layer. It separates you from all the outside world, all those microorganisms who want to eat you. All right? You have a cut in your skin. You have a broken barrier membrane. Your body has evolved to seal that as rapidly as possible to reestablish that boundary layer. Now, your body doesn't care what the end result looks like so long as the hole is fixed or repaired. So you can end up with a scar tissue. So we have a return to function, but we can lose our form. All right? Now, regeneration is recovery of both function and form, such that at the end of the day, when we have this regeneration, that the repaired aspect, injured tissue, doesn't look any different than the pre-injured tissue. Okay, that's regeneration, and that's different. Okay. So bone, first off, now let's go back. The liver is the only organ in your body that has the capacity to regenerate itself. And I mean that in the strictest sense. If you surgically remove up to 2/3 of your liver, the remaining liver tissue will start to replicate itself, and within a matter of weeks, it will reestablish its full size and function. All right? That's regeneration, not repair. All right? The closest tissue to liver in your body that has this capacity is bone. Bone has the capacity to, under the right circumstances, to regenerate. That means a full return of both form and function. All right? So let's talk about long bones. All right? So here's your femur. Let's say your femur, you fall and you break your femur. It's a nice clean break, not a compound fracture, just a simple fracture. What do? It's no longer function. You can't stand because this femur is now in two pieces. So what happens is it's like this. So what you're going to do is you're going to splint it, potentially cast it, so that you maintain this orientation, and then nature will take its course and this bone will regenerate. How does that work? So when you break the bone, that's going to break blood vessels. So what's going to happen? There's going to be a localized hematoma. What's a hematoma? That's bleeding within inside the body. All right. And that then will fill this. There'll be no empty spaces. The blood clot that forms there, this hematoma, will consist of platelets and other blood elements, which will initiate the initial healing phases. All right. So what happens early in time, here's our hematoma. We need to provide structural stability of these two broken ends. Okay, we want to keep them approximate to each other, mechanically stable. And that's the cast so that you can walk, all right, be ambulatory during this phase. And then what happens is that there is various signals that come from that hematoma that are going to attract fibrocartilage cells and blood vessels, and we will get the first callus, which is called fibrocartilage callus. This ultimately gets remodeled and replaced by a bony callus, and at this point, this is about 6 weeks out, your bone is essentially repaired on the way of being regenerated, because remember, the bone is constantly being remodeled. So this is, at this point, we have some mechanical stability. So they're removing the cast, but then over a period of months and years, that bone gets remodeled, and eventually it can be indistinguishable from the pre-injury site, depending on a number of factors that will can be affected. How well is the reapproximation? How is it stable? Blah, blah, blah. All these kinds of things influence it. But it has the capacity to not only repair, but to regenerate, right? Now, if we go way, way back, before we knew about mechanically stabilizing those broken ends, I mean, yeah, they could, if the broken limb, let's say, think about Australopithecus or something like that, and you have a broken femur, and it's like this. But because of the family group, he can be protected from predators and so forth. It repairs, but they didn't splint it because they didn't know about that technology. So it can heal just like this. All right. So that's why splinting is critically important. The first casting that I'm aware of historically was the Turks and the Ottoman Empire invented it. And basically, you have a person with a before that, they would just splint it and wrap like sticks and bandages. The first cast using plaster of Paris, classic, it's calcium sulfate. So basically, they had a wooden trough. They put the person with a broken leg in there, then poured the plaster of Paris. It solidified, and they didn't move for 6 weeks. Okay, so then. And when I was a kid, it was cheesecloth and plaster of Paris. Okay, and today it's fiberglass. All right. The differences are when I was a kid and you had plaster of Paris, when it doesn't do well in water. So you couldn't take a bath for 6 weeks. Believe me, you smelled to high heaven when it was all said and done. All right. Today, fiberglass, it doesn't matter. You can go in the shower, you go bathe, whatever. It's still going to stink, but not quite as bad. All right. So this is repair and regeneration. Now, this is basically more details. I'm not going to go into it, but I will say this. The conditions have to be good. They have to be appropriate. Now, there are conditions where bone has no ability not only to regenerate, to repair. If I have a bony defect, if it's a small enough bony defect, the bone can repair and regenerate. If it's too big, it can't. So there can be traumatic damage such that that bone cannot repair or regenerate itself. There can be disease or pathogenic pathologies that can block this from happening. Let's say you're a chronic diabetic, you smoke, all kinds of things that can contribute to incapacitate these bony repair strategies. Okay, so there still remains a lot of interest in the tissue regeneration, regenerative medicine field to promote bone repair. It's still a big problem. I mean, also post suppose oncology treatment. So you have cancer, you're using radiation treatment to kill the tumors, but that's going to damage the tissue, so it doesn't want to heal. So there are lots of instances where you want to help the body repair or regenerate itself. Okay. I have repeatedly talked about how bone remodels itself constantly. Every year, 10% of your skeletal mass is replaced. Every 10 years, you have a new skeleton, right? Now, what drives these processes? They're always driven by hormones. The two primary hormones, one you already know about, that is PTH. It's produced by the parathyroid gland and is an indicator how we can regulate blood calcium. And the role of PTH involves mobilizing bone stores of calcium. So that means in order to increase blood calcium from bone, I have to destroy the bone, which means I need to activate osteoclast, which will destroy bone, releasing the calcium. All right. Now, that's the one hormone that will increase calcium or reduce the calcium in bone. There has to be another hormone which will do the opposite. That hormone is calcitonin, which is on this slide too. And it has the opposite effect. It's also produced by the parathyroid glands, but it goes to bone and stimulates the bone to take in calcium and deposit calcium. So its job is to reduce calcium levels and correspondingly put them into bone, right? So remember, you always have to have one molecule that will drive that variable in one direction. You have to have another one to drive in another direction. You can't have one variable doing both, right? Now, next, the mineral of bone is hydroxyapatite. It consists of both calcium, which we know a bit about now, but also phosphate. Now, prior to about 20 years ago, we just kind of ignored the phosphate part. But what's important is I want to do a full circle. When I was talking about the first lecture and I told you you have your dense bone and how you have these osteocytes deep in bone, but they're all interconnecting with each other because of these channels called caniculi. And that these channels actually communicate to the outside of bone, to the rest of the body. They go from blood vessels to deep into the bone. So that, and I also mentioned that osteocytes are endocrine organs. So now let's talk, what do I mean by that? So what they do is they produce a hormone called fibroblast growth factor 23 or FGF23, right? Now remember, what are they're doing? They're also responsible for, I said they were mechanoreceptors, they're also endocrine organs. Let's focus on the endocrine aspects. What does FGF23 do? It regulates phosphate, all right? Now, it does it in a number of aspects. So number one, it will go to the parathyroid glands where it will reduce PTH. Now, PTH, what does PTH do? That results in the resorption of bone. Not only will that result in the release of calcium, but it also regulates the release of phosphate, okay? Now, it also, FGF23 goes to the left ventricle of the heart where it will induce hypertrophy or enlargement of the heart. It then also may play a role in hardening of the artery. So you have artery disease. We'll talk about that when we get to the circulatory system. But what can happen is these injured vessels can actually have calcium deposits. And it seems that there could be some role with that, but that's still being worked at right now. Just as important is that, so the goal over here is by reducing PTH, that's going to reduce phosphate levels in the blood because it's going to be not mobilizing bone stores. It also has a nutritional impact, and that means it's going to go to the kidney where it is going to increase the secretion of phosphate. which means that more phosphate is going to end up in the urine. That's going to reduce the circulating levels because it's leaving blood to enter the urine. It also inactivates or blocks the activation of vitamin D3. So vitamin D3 is not only involved in the absorption of calcium, but also in the absorption of phosphate. The net effect of FGF23 in regards to phosphate is to reduce phosphate levels, all right? Both nutritionally as well as from stored sources, right? Okay, with that, I want to focus on bone remodeling in terms of, I want to focus a base of everything I want to talk about for bone remaining here as some cartilage stuff at the end, but for the rest of the bone part, I want to focus on remodeling because this is critically important. All right. Now, so let's get some definitions. So bone remodeling assures us that throughout our lifetime, despite changing forces and things like that, our bones adapt. Okay. Our bones are continually adapting. That I could even say that there is little micro injuries, like when you're running or something, and your bones will repair themselves and become stronger as a result. Right now, if we're thinking in terms, and when we have the group of cells that are responsible for remodeling are going to be osteoclast, osteoblast. We destroy it, we rebuild it. All right. Now, we have our two types of bone. We have our cortical bone and our trabecular bone. Cortical bone is denser, therefore heavier. However, there is greater surface area with the trabecular bone. So even though the weight of your bone structure, 80% of it corresponds to cortical bone, because the trabecular bone has a much greater surface area, 50% of the metabolic activity is associated with trabecular bone, right? Now, if we drop on down and we have remodeling of each of these bones, cortical versus trabecular, I've kind of talked, when I talked about introduced lamellar bone at the beginning lecture series, let's go back and revisit that. Where does that come from? So we have a bone remodeling. So that means we've broken down cortical bone and remodeled it. We've broken down trabecular bone and remodeled it. In terms of cortical bone, that means that so here's the floor. Envision this is the ground level. There isn't a floor underneath me. If I start digging a hole, if I dig a hole, I'll eventually have a vertical tunnel, right? That's associated with cortical bone. If I'm talking about trabecular bone, we're talking about plates or struts. Here is a plate of trabecular bone. If I start to dig a hole here, what happens? I make a hole. It's not deep enough to make a tunnel. It just makes a hole, right? Now, so in the way cortical bone is remodeled, we have these long cutting tubes. I'll show you a picture in a moment. And then they fill them back in. In the terms of the plates and struts of trabecular bone, it's all surface erosion. But rather than being focused in a small area, just going vertically or horizontally or whatever, we talk about large surface areas of erosion and replacement. All right. So basically, that's the bone remodeling unit. And that consists of the degradation with the osteoclast and the reforming with the osteoblasts. After this is all done, we've had bone remodeling, we've had it destroyed and rebuilt. We call it a bone structural unit. And that's where the lamellar portion comes into play. What you're looking at when you see a Haversian system in cortical bone, that is after the fact. When you look at the lamellar lines associated with the plates and struts of trabecular bone, that is after the fact. Okay? Bone remodeling, again, if I will continue to drive this until you get it in your mind, is that we have to activate a bone remodeling unit. This is activating the osteoclasts. Then you have the active resorption, and then we have the formation of bone. So this is referred to as ARF or ARF. Okay? I didn't make it up. So when we talk, so how long does this process take? If we are talking cortical bone, it takes about 100 days. If we're talking about trabecular bone, it takes about 200 days. And this is because in cortical bone, we're talking about a small area. We're just going down like this. If we're talking about trabecular bone, it can be larger areas, so it takes a lot longer. So it doesn't take 100 days, it takes 200 days to have a complete remodeling sequence for trabecular bone. All right. Then there is this concept called activation frequency. This is the number of BRUs you have per bone at any given time. Let's take this tabletop. This tabletop is a plate of trabecular bone. If I have one bone remodeling unit here, what can happen? If it goes deep enough, it'll make a hole. So there's a hole here. Does that hole threaten the mechanical integrity of this tabletop? No. But let's increase the frequency. Now let's have 50 little holes. If we put enough holes in this tabletop, it's going to compromise its mechanical integrity. All right. So that's activation frequency, is the number of bone remodeling units you have going on at any given time for a given bone. Okay. And balance of a coupling. So under normal circumstances, when you destroy bone, formation phase always follows. So there's a balance maintained. We lose bone, we recover that bone, right? Now, if we fail to meet that, if we fail for that coupling fails, and we'll talk about instances when we can fail it, it's just an imbalance, and we're going to either end up with more bone or less bone. So all of you, everyone in this room, you're not growing any taller. Your growth plate's closed. But you will continue to gain bone mass until your mid-30s. All right? You're not growing any taller, but your bones are getting bigger, larger around. Right? So after your mid-30s, you're going to be losing bone from your skeletal mass throughout the rest of your life. Bone is being remodeled throughout this whole process. So let's think about the balance. Right now, you are in an acquisition phase of your lifespan. That means that your bone is being remodeled, but you're ending up with more bone than when you started, because you're acquiring bone mass, and you will continue to acquire this bone mass until your mid-30s. At that point, you're still remodeling, but you're losing bone, so the balance is now shifted to loss. All right? So I'm well past my 30s, hell yeah, and so I'm in loss phase. Okay, I am almost 2 inches shorter than I was in my prime. I also have less bone than I was in my prime. I also, other things have shifted as well. Muscles from up here, kind of down here, etc. But that's all with aging. All right. So let's go back now and talk about the differences between remodeling of cortical bone and trabecular bone. Remember, cortical bone, I'm making a tunnel. So what's driving that tunnel, drilling that tunnel, are the osteoclasts. They form what's called the cutting head. They're secreting acid. They're secreting acid-activated proteases. Together, these remove bone. And they will then just continue in this thing. They make a tube structure. Now, this is the activation and resorption phase. Now we need to go the formation phase. Now, think about here's a cross section of that cutting tube. It looks like this. Now, osteoblasts come and then populate around here. They're going to secrete osteoid underneath them. So that creates a layer of osteoid underneath those osteoblasts. That becomes mineralized, and that makes a lamellar line. Then the cells stay on the top. They secrete more osteoid. That becomes mineralized. They keep doing this. We get these concentric circles, if you will, decreasing until the point where they have a hole, which is called the Haversian Canal. They do not completely seal up, because we need the Haversian Canal for blood vessels as well as nerves, right? So that is what you're seeing here. So here is the cutting comb, that's at the head. And then at this point, these are lamellar cross-sectional lines. Remember, this is what it looks like, the finished product. So we now have this osteoblast always staying here. They're secreting osteoid. That becomes mineralized, and that makes these lamellar lines. This is the osteome. Remember, that is after the fact. And we have our Haversian canal or hole in the middle, right? So this is cortical bone, a bone remodeling unit. What about trabecular bone? I want to focus on trabecular bone because this is where most of that metabolic activity is happening, all right? Now, it takes not 100 days, but 200 days. And if we look here, we're going to present it like this. So it's on the surface of the bone. And basically, time, this is 0, this is 200 days, all right? So we have activation. We now have the osteoblast in the active resorptive phase. And so we're talking about this tabletop. So the tabletop is getting thinner because we're losing bone. Let's say it starts out at 60 microns. When it's done, it could be 0 microns. All right. Now, that process takes about 50 days. Now what happens is we get in the reversal phase. And remember, osteoblasts do not secrete bone. They only secrete the organic portion, the osteoid. Once it's secreted and outside the cell, then it can mineralize, and only then can we call it bone. So there is a matrix deposition phase of which the osteoblasts are laying down this osteoid. That becomes mineralized, and now we have bone. There is always, the mineralization phase will always, by definition, it has to always follow matrix deposition. There's always a lag phase associated with mineralization because you have to have the matrix first because that forms the nucleation sites for mineral deposition to make bone. Now, so if we look at this process, it's 200 days. 50 days represents the resorptive phase. By far, the greatest extent is going to be for the matrix deposition and subsequent mineralization. Now, you guys are not growing taller, but your bones are growing bigger. Then this represents remodeling. So your long bones can grow bigger and wider. You gain, and you're gaining bone mass. All right. Now, this is all endochondrial for long bone formation. We've already talked about that. I'm not going to spend any more time. So let's look at these bone remodeling and balance. All right. So let's strip everything down to this. So we have, and this is time, 0, 200 days. We now have a bone thickness before we start. Okay. Now we initiate or activate resorption phase. We're losing bone thickness. This is the action of, and that is the rate at which we lose bone is referred to as the erosion rate, the rate of bone loss. At some point, and that is the active erosion period. Now we reach our maximum depth of erosion. Let's say it goes to 0, from whatever the thickness is to 0. And then we have the reversal phase. And this means that the osteoblasts will now start secreting osteoid. Then there is the mineralization lag phase that follows. Ultimately, with time, here's our mineralization lag phase here, matrix deposition rate, and then our mineralization rate. And at this point, we have remodeled bone, or our osteome. Now, what's going to affect this? So these are fairly obvious, so I won't spend a lot of time. Erosion depth. How deep does this erosion period take? If it's deep enough, you get a hole, right? The thicker it is, that means the longer you can resorb without compromising the mechanical integrity of that bone. And lastly, frequency. All right. So if I have many more of these per given area, that's going to subsequently weaken bone. So the most important aspect here that can be altered is typically going to be activation frequency. All right. Now, let me give you a couple of examples. Some pathological conditions, etc., so we can see how these bone remodeling units can change. So look up at the top. The top is a normal bone remodeling sequence for cancellous or trabecular bone. It's 200 days long, and we start with let's say our trabecular bone is 60 microns thick. At the end of the resorptive phase, just keep it simple, it's 0. Then we have our matrix deposition phase followed by our mineralization phase. This is complete by 200 days. We end up with a post remodeling thickness of 60 microns. The pre was 60, the post is 60, therefore the delta P is 0. There's been no change in total bone volume, all right? Total bone mass. Now, what happens in hyperthyroidism? Remember your endocrinology. So hyperthyroidism means that your thyroid is overproducing thyroid hormone. Thyroid hormone is one of its jobs is to speed up metabolism. So if you suffer from hyperthyroidism, that means your metabolic activity speeds up. That means all these metabolic processes speed up, including bone remodeling. This will significantly impact the bone remodeling sequence because it shortens it from 200 days to 100 days. This has a disproportionate effect on the overall bone remodeling. It does not have a significant impact on the resorptive phase. That still goes down to 0. However, it does have a significant impact on the matrix deposition rate as well as the mineralization rate. Both of these take time, of which we've deprived this sequence of time. So what happens is, by shortening this sequence, we're going to end up with less bone because I don't have time for osteoblasts to lay down matrix and for that matrix to become mineralized. The opposite effect would occur if I'm talking about hypothyroidism, not enough T3, T4. This means I slow things down. Now we're going from 200 days to 800 days or so. That means that I'm not going to have any significant impact on the resorptive phase, but that means I overall have much longer time for matrix deposition and mineral deposition, and I'm going to end up with significantly more bone at the end of the day. In case of hyperparathyroidism, there's no real significant change. That gets us to a pathology referred to as osteoporosis, which I'll define in a minute. But in this case, there's a disruption in the normal balance, and I will end up with less bone, right? So let's talk about osteoporosis. Osteoporosis is basically characterized with low bone mass compared with age-matched controls. So in other words, we're not going to compare your bone mass to my bone mass because I'm losing it, you're gaining it. That means that you are of a similar age, then we can compare your bone mass. If your bone mass, and we normally do not think of osteoporosis in you because you're acquiring bone mass, it's in my generation. So for me, that means that if I've got a bunch of old farts, they're the same age, if we have one subgroup of that which has significantly less bone than their age-matched controls, we call that osteoporosis. All right. Now, it occurs more readily in females versus males, and it is a significant issue because what it does is it weakens the bone. That means it's subject to fracture, not spontaneous fracture per se, but you have a traumatic injury, there's more likely to have a fracture result. For instance, if you're falling down, what are you going to do? You're going to throw your arms out, right? And that means your wrist could be subject to fracture. Or if you're falling down this way, that means you're going to land on your hip. That means your femur is subject to fracture. So there's 3 places that are subject to fracture, primarily the wrist, the hip, there can also be some spontaneous fractures in the vertebral fractures because gravity can compress enough and they can fail that way. They can be squished a little bit, okay? Now, I told you that I'm about 2 inches shorter than I was when I was your age. That is not because I've lost bone. That's because primarily the space between my vertebra, those vertebral discs, they're compressed over many, many years. So that means there's less distance. So I've lost the height here in my spine. Right? That's going to happen to you guys too. Right? It's just inevitable. All right. Oh, you can get in those. I've seen those exercise devices where they show these guys hanging by their feet, swinging by their feet, and that's supposed to extend and reduce that. Maybe, I don't know. So I'd have to have it proven. All right. So osteoporosis is really important, especially because we're an aging population. This is what's going to result. The normal trabecular bone looks like this. Notice the plates and struts. Over here is osteoporotic. Note all of the pits. That means it's weaker. There's less bone. That means that there's less resistance to stresses being applied. Now, what leads to fractures? Let's say hip fractures. It's not an issue right now, but when we get winter in Pittsburgh and there's ice on the sidewalks, this is a significant possibility, especially with the aging population. So what results in a fracture are two things. It's the bone quality and then the trauma event. All right. So let's start with bone strength. That consists of quality and quantity, not one or the other, but both of those. So in osteoporosis, you're losing bone quality and obviously bone quantity. This means you have overall less bone strength. That means there's less protection of that bone is less resistant to physical forces being applied, i.e. trauma. Trauma is a function of two things. It is a function of the risk of falling as well as basically the force of impacts. So let's think in terms of an old fart like me. One of the things that happens as I get older, my sense of balance is not what it used to be. My eyesight isn't what it used to be, which means there's a greater risk of me falling. Okay? Now, usually what happens as we get older, we lose weight. Weight also means soft tissue. Soft tissue, i.e. as in muscle. Let's say my thigh muscles. I'm losing thigh muscle. That means I'm losing the protective layer of soft tissue surrounding that femur. And if I lose enough of that, means that there's not a soft cushion to help protect the bone. The less muscle mass I have, the more possible direct contact that bone has with that traumatic force, and it's more likely to break. Okay, so fractures are more complicated. It's not just, oh, I just fell. I mean, it's a little bit more complicated, and it is a function not only of the trauma event or the risk of it, but also the quality of bone. Now, how do we measure bone strength? I can physically quantitate bone strength. All you have to do is give me some bone. That means that I could ask you, you would be put under a local, and usually we would take the bone from the pelvis. I'll take a bone core from your pelvis, and I can do an actual materials. I can do failure tests, etc. I can tell you exactly how strong that bone is. You will only let me do that once, if you let me do it at all. And you're stupid if you let me do it more than once. All right? So that's not how we measure bone strength in a clinical situation. What we do is indirect. We use x-rays. The greater the bone, the greater the opacity of the x-ray. So that means more opacity means more bone means more strength. It's all indirect, but that's the only test that we have that we can do with minimal threat to the patient that can give us a measurement over time. We call that the bone mineral density test, or BMD. Okay. Now, remember the risk of osteoporosis, and the purpose of this is to predict the occurrence of osteoporosis. Now, we're primarily interested in women versus men because there is a far greater instance in women than men. So, ladies, there will be a point in your life, say in your 40s before menopause, when you will get a 0 time point BMD. Usually that means you're usually using your wrists, because this doesn't change no matter whether you're losing weight or gaining weight, this stays the same. And what they do is they will take a reading. There's huge variability. Just look in this room. All of you in this room are different sizes and all of that. That means that everyone here, there's going to be a huge range of bone strength estimated as BMD. But you do this over a population group. And then what they're doing is now you measure this as you get older, especially post-menopause. What you're looking for is a significant change from age-matched controls. What they don't want is, let's do this. Do I have a piece of chalk here? Yep. This would be the only time you're going to see me draw, about the only time I see me draw on the board. Time, bone mass, okay? When you're born, you have a specific size, you have some bone mass, all right? So let's start with you because you're simple in many ways. All right, so we'll start here with guys, all right? So you're going to start here, you're going to continue to gain bone mass until your mid-30s. After your mid-30s, you're losing it the rest of your life. Ladies, population, you're going to be smaller than your male counterparts. So you're going to start out less, but you're also going to acquire it, but you're going to have less total bone mass because, generally speaking, you'll be smaller. And then what happens? You're going to lose at the same rate until menopause. We'll go over menopause and get to reproductive, but that means your ovaries are not making, there are no more eggs. No more eggs means no more estrogen. No more estrogen means reduced bone quality. So that means that without that estrogen to maintain support, that you get an increase in the rate of loss, right? Now, if we draw a line across here, this means that once we drop this line, we're in greater risk of fracture because our bone quality and quantity is reduced, okay? Everyone's losing bone. So if I take a 90-year-old person, normal everywhere else, their bones are fragile compared to you, all right? That's this. Now, what we're interested in is we're interested in this rate of loss. Guys, we're not so worried about. Women, yes. So we want to make sure that we postpone when they cross this line. We want to keep this above this line as long as possible. Ultimately, it will go below that line, but we want to postpone that as much as possible. All right? So thinking about this, there are things we can change and things we can't change. Okay? But we'll get into that in a moment. All right? So what you're looking at over here is how the BMD is impacted by size and things like that. All right? When we go to the next slide, there are obviously things that you can't change. You can't change the egg and the sperm that combine that ultimately make you. That's going to dictate how big you are, etc. Your sex, your age, your body size, ethnicity, etc. Those things you can't. Those are fixed. Let's do an illustration. Okay. Take your right hand, your thumb, and your index finger. Your left wrist. Why the wrist is because no matter what kind of weight changes, this doesn't change. What we're doing is we're going to give an estimate of your skeletal frame. Okay? There are 3 skeletal frames. We have a robust skeletal frame, then normal, whatever that means, and then a petite body frame, right? So in a petite, we have smaller, more fragile, more petite bones, robust, heavier bones. All right. So take these, go just below your palm, and can your finger touch your thumb? If it just barely touches it, we're going to say that you have an average bony frame. If you cannot touch it, that means you have a thicker bone, so you have a robust bony frame. If you significantly can overlap those, then you have a petite body frame. All right. So what does that mean? Using these, this is male, this is female. This is robust skeletal mass. This is a petite skeletal mass. So if you have a petite skeletal mass, that puts you automatically at risk for eventual failure sooner in your lifespan than someone with a robust frame. Everything else being equal. All right. Now, that gets us to what can we change? We cannot change menopause. When those eggs are gone, those eggs are gone. We can provide estrogen treatments. Okay, that can work. We can also, what's important is you need to also eat. You also need to exercise. All right. Don't smoke, don't excessively drink, etc. All of these things are important. Okay. So, yeah, we can talk about how estrogen treatment, I can remember when that was in clinical trials in the mid-'80s, and then the initial clinical trials really looked good. So all physicians started prescribing estrogen treatments, replacement therapy post-menopause. The final conclusive experiments didn't resolve themselves to the early 2000s. In the early 2000s, what happened was this. Yes, estrogen treatment, replacement therapy worked. You could retain bone. However, it puts you at significantly increased risk for cardiovascular issues. And you could get equivalent protection by just taking Tums. Right? So what it comes down to this, what can you do here? What can you do? You need to invest now. You want to have as big, great a skeletal mass as you can acquire. And it's not magic. There's two things you need to do. A source of calcium and or vitamin D3. Why do I say vitamin and vitamin? You are CMU students. That means you abhor daylight. You need sunlight on open skin in order for your body to make vitamin D3. Okay? So if your skin doesn't make it, you need to get it in your diet. All right? It's easily done. Calcium, I don't care if you're lactose intolerant, doesn't matter. There's all kinds of calcium sources, even Tums. Okay? So, but that's just half of it. You need to have dietary sources of calcium associated with vitamin D3 to get uptake to maintain your bone mass, but you also need to exercise. Remember Wolff's Law. So together, that can help you to maximize. And then continue that process as you get older, and that reduces the rate of bone loss as well. All right? All right. So, guys, you don't have menopause, but you still can have osteoporosis. For guys, typically it's induced with various treatments. So in this case, let's say we have a guy suffering from arthritis, and they're going to put him on glucocorticoid treatments to suppress the pain associated with the arthritis. This, again, is not without cost. So chronic application of glucocorticoids is going to result in a loss of bone remodeling balance. Basically, it's going to shift everything to resorption, as well as the expulsion of calcium from the kidney and the urine, and it increases PTH, which is going to increase resorption. Everything increases calcium in the blood, and that means more calcium is going to leave via the urine, and we're going to lose bone mass. And this is one example how guys can suffer from essentially osteoporosis induced by glucocorticoids. Okay, I still have 10 minutes. I'm going to give you the short and the dirty because I want to finish up. So this is cartilage. So remember, I introduced cartilage. Cartilage is associated in various. It's on the ends of long bones, short bones. It is also associated with your thoracic cavity because the rib bones do not fuse and become a solid piece of bone. If they're a solid piece of bone, that means they couldn't expand and contract. That means you couldn't breathe. Okay, so cartilage allows the rib cage to expand and contract. It allows you to breathe. You also have a cartilage associated with your ear and your nose. All right, as well as in your respiratory system. So we'll get into the respiratory system later, but you have rings of cartilage that are in your trachea and your primary bronchioles, and what they do is they maintain your airways. They keep them open, whether you're breathing in or not. So they keep them open. By keeping them open, that reduces the resistance of air movement through those channels. So that is another role for cartilage. Now, we are talking bones, so let's talk about joints. And you know something? We can talk about three types of joints. We can have synosternoses, which don't move. We can have, and then basically we can have slightly movable joints and freely movable joints with their diarthroses. Don't worry about them. Okay, I'm not going to ask you a question. It's just for your own edification here. I'm also thinking of time. So these are where you have joints. These are everywhere where you have two bones or more coming together. Okay, right? These joints could be movable or not movable, or partially movable. Now, let's focus on those movable joints. So we can talk about our knee, we can talk about our hip as examples. We'll talk about our shoulder in a second. So if we go up here, let's say with a knee, I know this is not the appropriate bones, but basically, and these freely movable joints, the joint is contained within a synovial space here. So here's cartilage on either end. We have ligaments and tendons that maintain the quality of this joint. And then we have this synovial space, which is filled with the synovial fluid that moves and helps provide cushioning in addition to the cartilage, right? Now, let's move down here to the shoulder. That's here. This is a much more complex type of joint. So here's the head of the femur. Here's our shoulder. And what we actually have here is we have something called the bursa here, which is a synovial sac, which acts to separate these two movement tissues here, and it kind of moves this way and this way. So basically, as we are moving our arms up and down, this sac is moving as well. So that's a different, more complex joint. All right. So we now move to the femur here. And here we show, remember, what's a ligament? A ligament joint is this soft tissue which connects bone to bone. A tendon connects bone to muscle. Remember, we talked about tendon when I was talking about skeletal muscle. So this is the bone end of things. So a tendon is bone to muscle. A ligament is bone to bone. Now, in your joints here, these are ligaments. And their primary job here is to formulate and maintain this joint space. Right? So they keep that head of that femur in the acetabulum. If those ligaments fail, it doesn't work. Now, ladies, I don't know if you guys did soccer when you were teenagers, but one of the problems with teenage girls playing soccer, especially 12 months out of the year, is during the growth phases and all that, they do not have stable knee joints. They're unstable knee joints, and those ligaments are subject to fail. You can have, and this is rather common, all right? I'm not a proponent of a single. I like it when I was a kid, you played sports at specific times in the year and you played different sports throughout the year. So you're exercising different stuff. That's all. No one does that anymore. Everybody focuses on one activity. That's not a good thing, but that's neither here nor there. All right. So our joints here. And I think, yep, that's it. So basically, I'm not going to ask you any questions on the exam. That'll be in the near future concerning the cartilage so much. I just want you to appreciate. So from these last few slides, cartilage is important. It forms a number of forces. It's at the ends of joints. We have, think about what are ligaments, what are tendons. You don't need to worry about different types of joints per se. All right. So with that, we are now concluding the skeletal system and we'll be moving on. If I'm not mistaken, it's cardiovascular. I have to check my calendar. All right. So I'm letting you go early a couple of minutes. So welcome back, everybody. And let's finish the rest of the semester. Okay.